welcome to the World Thrombosis Day 2024 webinar, co-hosted by the ISTH World Thrombosis Day campaign and the Division of Blood Disorders and Public Health Genomics at the Centers for Disease Control and Prevention, also known as the CDC. We are happy to have you here with us today for an exciting roundtable discussion on women's health and thrombosis. We have a panel of experts from around the world to share their experience with women's health and thrombosis. My name is Lena Castellucci, and I'm a thrombosis physician and researcher based in Ottawa, Canada. I am also proud to serve as the chair of the World Thrombosis Day Steering Committee, and I will be moderating today's roundtable discussion. For today's discussion, we will be shining the spotlight on women's health considerations as it relates to thrombosis medicine. Thrombosis is the formation of blood clots within blood vessels, and it can pose significant health risks for women, especially during key points in their lifetime, such as pregnancy and the postpartum period. Also of importance is when women are receiving exogenous hormone therapies, such as oral contraception or hormone replacement therapy. It's important for us to understand that we manage these risks appropriately and understand how to approach these cases on an individual basis so that we can increase awareness and ensure early detection and appropriate treatment is started. Today, we will have a thoughtful discussion with our expert panelists, and I will now begin by introducing each one in turn. Dr. Naomi Tepper joins us from the United States, where she is the medical officer in the Division of Reproductive Health at the National Center for Chronic Disease Prevention and Health Promotion at the CDC. Her specialty is obstetrics and gynecology, and we are very excited to have her expertise with us today. Next, we are joined by Dr. Danny Sue from Sydney, Australia. Dr. Sue is the Director of Therapeutic Apheresis and the Clinical Lead of Immune Hematology at Liverpool Hospital. We are also thrilled to have Dr. Helen Okoye from Nigeria. Dr. Okoye is an attending physician and thrombosis specialist at the University of Nigeria Teaching Hospital with a special interest in women's health. And our final panelist today is Professor Fionnuala Nyanley from Dublin, Ireland. She has a passion for women's health and serves as a consultant at several Dublin hospitals. She also serves as the director for the Irish Network of VTE Research and is the national lead for VTE Patient Safety Program. Before we get started with our presentation, I would just like to highlight that the World Thrombosis Day Steering Committee and the campaign is going to be conducting an international survey of women who have been pregnant or experienced the postpartum state in the last 6 to 12 months. And we are doing this survey in an international fashion so that we can gain an understanding of what women experience across the world with respect to education about thrombosis and whether their experience has some information that can be shared on a global scale so that we can try to standardize what we are sharing in terms of risk factors, risk mitigation, and how we can communicate these concerns with our patients directly. I'm excited to say that the survey has been translated in more than 10 languages so that we can increase our reach across the world. And the survey will go live in the next couple of weeks. And once we have the results, we'll be excited to share that again with one of our partner organizations. And now I'd like to bring us over to Dr. Tepper, who is going to share her insights through a presentation.
Thank you so much. I hope you can all see the slides. Thank you so much for that kind introduction. I'm really honored to be part of the session today. As mentioned, I'm an obstetrician gynecologist at the U.S. Centers for Disease Control and Prevention, and I work in the Division of Reproductive Health. One of our, we have several priorities. One of our main priorities is promoting high quality reproductive health care, of which contraception is an essential component. And so I'm going to talk about hormonal contraception. I'll talk about the methods that are available in the United States. And again, acknowledging World Thrombosis Day, we'll talk about the risks of thrombosis with certain hormonal contraceptives. I'll then talk about CDC's contraceptive guidelines for healthcare providers. And these were just recently updated, actually just published in August of this year. So I'll share a few of those updates. First, hormonal contraception, just a quick Reminder, hormonal contraception is broadly divided into two categories: combined hormonal methods and progestin-only methods. I just want to mention there are other hormonal methods available globally, but I will only be addressing methods that are approved in the US. And of course, there are other important methods of contraception, such as copper IUDs, sterilization, barrier methods, etc. But we'll just be focusing on hormonal contraceptive methods. So the combined methods contain estrogen and a progestin, and they come in a pill format, transdermal patches, and vaginal rings. Traditionally, ethinyl estradiol has been the estrogen component in pills. There are now some newer pills that contain estradiol valerate and estetrol. And while there's limited evidence, it is possible that these formulations are less thrombogenic than ethinyl estradiol. Ethinyl estradiol is also in the transdermal patches and in the vaginal rings. The progestin-only contraceptive methods are an intrauterine device, or IUD, a subdermal implant, an injectable, and progestin-only pills. The IUD contains levonorgestrel. The implant contains etonogestrel. The injectable is depomedroxyprogesterone acetate, or Depo-Provera, or DMPA. And there are several formulations of progestin-only pills. One recent exciting development is the norgestrel progestin-only pill was recently approved by the U.S. Food and Drug Administration, or FDA, for over-the-counter access. So it had been long approved as a prescription product, but is now available over-the-counter, which is very exciting for contraceptive access. This is kind of the main point that I hope you'll remember if you remember nothing else. Hormonal contraception is safe for most people who wish to use it. I'll just repeat that again. Hormonal contraception is safe for most people who wish to use it. However, as we are aware, some hormonal contraceptives are associated with an increased relative risk when compared with non-use for thrombosis, and that includes venous thromboembolism, DVT or PE, and arterial thromboembolism, stroke or MI. Sorry, the formatting of the slide is a little bit off, but I just want to put these risks in context and think about it in the absolute risk in the general population. So thrombosis is a relatively rare event in females of reproductive age. For a non-pregnant, non-COC user, about 1 to 5 women per 10,000 per year will develop a clot. This increases somewhat to 3 to 9 women per 10,000 per year with use of combined oral contraception, but is still lower than the risk during pregnancy and the postpartum period. And so it's important to keep these absolute risks in mind as you're counseling patients about all of the risks and benefits of contraception. This is a busy slide, and so we're going to break it down. But basically, what are the relative risks for certain hormonal methods when compared with non-use? For combined hormonal contraceptive methods, the evidence is fairly consistent that the relative risk for VTE is higher compared with non-use. So the risk ratios are about 3 to 7.9. The risk for stroke and myocardial infarction is somewhat lower than VTE, but is still elevated on the order of about 1.6 to 2.5 times compared with non-use. For progestin-only contraception, traditionally it was thought that these did not carry an increased risk for thrombosis. Most evidence has found that there is not an increased risk with use of the IUD, the implant, or progestin-only pills. However, there's an accumulating body of evidence on the injectable DMPA, which has found that there is an elevated risk for VTE compared with non-use, about 2.6-fold higher. The mechanisms for this are not clear. It's possible that this is related to a relatively higher dose of progestin that's delivered with the injectable. The relative risks for stroke and MI do not appear to be increased. So what about if a person has a medical condition? These medical conditions are certainly common in the US and globally, and some of them carry an increased risk for thrombosis, for example, hypertension, diabetes, and many others. Contraception for these individuals may be particularly important because pregnancy itself is risky. However, what happens if a person with a thrombogenic condition uses hormonal contraception? So there's somewhat limited evidence on this. Most of the evidence for combined hormonal contraception is in users of combined oral contraceptives, and studies have found an increased risk for thrombosis with increasing age, smoking, obesity, hypertension, and several other conditions. Unfortunately, there's no evidence on individuals using the patch or ring with thrombogenic conditions, and there's no evidence on most other thrombogenic conditions. And some of the ones listed on the slide, there's very limited evidence, 1 or 2 studies. For progestin-only contraception, there's even less evidence about use with thrombogenic conditions. There are a few studies that have not found an increased risk for thrombosis with use of IUDs, implants, or progestin-only pills in a person with a thrombogenic condition. There have, however, been 2 studies looking at people with certain conditions who use DMPA, and there has been found to be an increased risk for thrombosis among women who are postpartum and women with diabetes. However, there's very limited evidence and no evidence on most other thrombogenic conditions. So I want to shift gears and talk about our contraceptive guidelines. What can healthcare providers do when they're counseling their patients, particularly with medical conditions, about safe use of contraception? So I'll talk about the guidelines and then again share some of our recently updated recommendations. The main guidance document I'll be talking about is the Medical Eligibility Criteria for Contraceptive Use, or the MEC. And as I mentioned, we just recently released a fairly large update in August of this year. The MEC provides guidance for safe use of contraception by people with certain medical conditions and characteristics. So for example, is it safe for a person with hypertension to use combined oral contraceptives? The MEC actually contains over 1,800 recommendations for over 60 medical conditions and characteristics. Historically, women with medical conditions were often denied access to contraception because of safety concerns and a lack of guidance for healthcare providers. So to combat that, the World Health Organization, or WHO, published evidence-based contraceptive guidelines. They were first published in the 1990s and have been updated since that time. And really, the goal is to reduce barriers to access. If you look through the full MEC, you'll see that many women with medical conditions can safely use most contraceptive methods. There are, however, some medical conditions for which certain methods may be unsafe. At CDC, we adapted the WHO guidance for the United States. We published the first issue in 2010 and have made several updates since that time. I just want to mention our other large guidance document so that you're aware that it exists. The Selected Practice Recommendations for Contraceptive Use, or the SPR, provides guidance for common but sometimes complicated issues in managing contraception. So when during a person's cycle can a method be started, what to do if a person has bleeding irregularities while using a method, and many other recommendations. And together, the goal of these documents, again, is to remove unnecessary medical barriers to accessing and using contraception. We have a fairly rigorous process for updating our guidelines. We continuously monitor published evidence on contraception. There's a system, the Continuous Identification of Research Evidence, or CEER system, that was created for WHO. So we're continually monitoring published evidence. We conduct systematic reviews to gather all of the information on a particular topic. We consult with subject matter experts, including national experts in contraception and family planning. And if we're considering a particular medical condition, we will consult with experts in that condition. So, for example, hematologists. And CDC then decides the updated recommendations and publishes these. And again, we recently published some updates in August of this year, so we're really excited about that. The MEC works by having a category for each medical condition and contraceptive method. The categories are 1 through 4. A 1 means there's no restriction for that contraceptive method in a person with that medical condition. An example would be a person with migraine headaches who uses a copper IUD. There are no safety concerns. A 2 means the advantages generally outweigh the risks. A 3 flips the risk-benefit ratio and says that the risks usually outweigh the advantages. And a 4 means there's an unacceptable health risk if a person with that medical condition uses that contraceptive method. So an example would be a person with current breast cancer using combined hormonal contraception is a category 4. The color coding is somewhat intentional. The 1s and 2s are green lights, meaning generally proceed with using that method. And 3s and 4s are generally proceed with caution and counsel about additional contraceptive methods. This is just to show an example of how this looks. So this is for the condition of smoking, which is subdivided by age and by level of smoking. The contraceptive methods are copper IUD, levonorgestrel IUD, implant, DMPA, the injectable, progestin-only pills, and combined hormonal contraception, including pills, patch, and ring. At a glance, you can see that most methods are category 1, meaning safe for use. On the far right-hand side of the slide, you see combined hormonal contraception increases from a 2 to a 3 to a 4. And that is because of increasing concern about the baseline thrombosis risk as somebody's age and level of smoking increases. This is a busy slide, but at a glance, we created this to show all of the changes that were made in the 2024 US MEC. We added a few new medical conditions. In some cases, we decreased the numbers, reflecting less concern about safety. And in some cases, we increased the numbers, reflecting more concern about safety. And so I just want to share 3 of the recommendations that were just updated, and these were updated based on new evidence and concerns around thrombosis risk. So for people with thrombophilia, sickle cell disease, and DVT or PE on anticoagulant therapy. First, thrombophilia. This shows the 2024 recommendations for people with thrombophilia. And I just want to focus on the change, which was for DMPA. You can see it's a category 3, meaning the risks outweigh the benefits. Previously, in our previous iteration of the guidelines, it was a category 2, meaning the benefits outweigh the risks. So you can see the number increased, and this was related to a couple of bodies of evidence. First, the systematic review found fairly limited evidence on progestin-only methods in people with thrombophilias. However, there was a study that found that people with factor V Leiden who used DMPA had an elevated risk for VTE. There was no evidence on many of the thrombophilias. And the other piece of evidence that fed into this was the accumulating evidence of DMPA as associated with thrombophilia in the general population. So this number was increased related to increased safety concerns. To sickle cell disease, you can see the recommendations here for people with sickle cell disease. And I just want to focus on two changes for DMPA and for combined hormonal contraception. First, DMPA, you can see that it is a 2/3. In looking at our previous recommendations, DMPA was actually a category 1, meaning no safety concerns. You can see now that it is a 2/3, which is a bit of an odd recommendation. There are a few situations in the MEC where there's a slash, which indicates a need for some clinical judgment. And there's a clarification that goes along with the numbers that says the category should be assessed according to the severity of the condition and risk for thrombosis. And so this is somewhat intentionally vague because we rely on healthcare providers' clinical judgment about whether their particular patient with sickle cell disease may be at higher risk for thrombosis and whether DMPA may or may not be safe for them. There was very limited evidence on individuals with sickle cell disease using progestin-only contraception. However, limited evidence did not appear to show an increased risk, but there were two sort of bodies of evidence that fed into this change. First, the increased recognition that sickle cell disease itself is significantly associated with thrombosis risk. And then also the evidence on DMPA risk in the general population. And so these two together led to some increasing concern about this method for people with sickle cell disease, and hence the change in the recommendations. For combined hormonal contraception, the recommendations are category 4, meaning generally unsafe for use. Looking back at the previous recommendations, it was a category 2, meaning the benefits outweigh the risks. So you can see this is a fairly significant change from a 2 to a 4. And again, limited evidence, but the systematic review found a study of individuals with sickle cell disease using combined hormonal contraception who had a higher risk for thrombosis compared with non-use. And again, also the understanding of sickle cell disease as a significant thrombosis risk factor. And that together led to the change to increase the numbers based on increasing safety concern. Finally, DVT or PE on anticoagulant therapy. This is actually just part of the recommendations for DVT PE. There are several other subconditions, and if you look in the full guidelines, you can see all of them. But I wanted to focus on the changes. So first, we made some changes in the subcategories. There are now separate recommendations based on whether someone is on a therapeutic or prophylactic dose of anticoagulants. If someone is on a therapeutic dose for a DVT or PE, combined hormonal contraception is a category 3, meaning risks outweigh benefits. However, going back to our previous recommendations, it was a category 4, meaning generally unsafe for use. So this was based on, the change was really based on one study that found that individuals on therapeutic doses of anticoagulants who were using combined hormonal contraception had a similar risk for recurrent VTE as those using estrogen-containing methods and non-hormonal methods, and progestin-only methods and non-hormonal methods. So their risks were similar. And so the number, in fact, was decreased in this case, reflecting a decreased safety concern, although still with caution, given that the risks still outweigh the benefits. So I've alluded to this throughout, but there are a lot of research gaps in the evidence needed to inform these guidelines. And so we actually will be publishing a manuscript on several of the research gaps that we noted throughout our update process. We hope this would stimulate further research in these areas. I'll just highlight a few of the knowledge gaps here. So for people with thrombogenic conditions, what is their baseline risk for thrombosis? And in particular, females of reproductive age, there's more evidence on thrombosis risk in older ages, and often genders are combined. We are really interested in what is the risk for females of reproductive age who have a thrombogenic condition. And then are there differences by disease subtype or severity? So for example, for a patient with sickle cell disease, are there certain disease characteristics that might predict whether they're at higher risk for thrombosis? And then for people with thrombogenic conditions who use hormonal contraception, what is their risk for thrombosis? And are there disease subtypes that could predict risk? For example, for a person with sickle cell disease who wishes to use DMPA, are there certain disease levels that might help predict their thrombosis risk? And there's a lot to learn about the mechanisms of thrombosis associated with hormonal contraception. So, and are there biological interactions between the hormonal contraception and the medical condition that might further elevate the risk for thrombosis? So I just want to finish by sharing where you can find our guidelines. Certainly no one can be expected to remember all 1,800 of these recommendations. So this is CDC's contraception homepage, and you can see there's a section for healthcare providers, and here you can access the MEC and the SPR. And we also have a free app which is available at your app store if you search for CDC contraception. It is updated whenever we update the guidelines, and so hopefully that will help you to have the guidelines at your fingertips. In summary, most people can safely use most contraceptive methods, including hormonal contraception. Some hormonal contraceptives are associated with an increased risk for thrombosis, which may be further elevated for people with medical conditions. Thrombosis is overall rare among people of reproductive age who use hormonal contraception and is still less common than the risk during pregnancy and postpartum. Contraceptive guidelines are available from WHO and CDC that can help support healthcare providers as they counsel their patients on safe use of contraception. I thank you very much for this opportunity, and I'm looking forward to the coming discussion. Thank you.
Summary of the exciting changes that have happened in the United States. I think one of the questions that came to my mind, you mentioned very early on in your presentation about the newer preparations of estrogen. And I wonder if you could speak to if there is minimum dosing associated with those new preparations of estrogen and how that confers risk of VTE. So in other words, can healthcare professionals prescribe the lowest dose of estrogen to help minimize risk of VTE?
Yeah, that's a great question. So it does appear that the risk of thrombosis with estrogen preparations is somewhat dose dependent. So when we used to have higher dose combined oral contraceptives, those carried a higher risk for thrombosis. And as ethinyl estradiol dose has decreased, the thrombosis risk has somewhat decreased. Currently, these newer formulations are still fairly new in that we don't have a lot of different doses or an understanding of what the thrombosis risk is. It does seem that these formulations may have less effect on the liver and on coagulation parameters. So they may cause less risk for thrombosis when compared to the ethinyl estradiol doses.
That's great. Thank you for that. Very much appreciated. Really exciting as well that in the United States, there are now some preparations that are available without a prescription. And is that nationwide?
It is nationwide. This formulation was already approved by the FDA as a prescription product. And so they went through a process to assess the safety and determine that it was appropriate for over-the-counter use. So it is approved and available nationwide. We are trying to keep tabs on whether there are still challenges to access, for example, the cost, or is it locked behind a counter at a pharmacy? But we're still excited that it is available.
Yeah, that's a very exciting thing. I'm going to just lead us into a series of questions, and we'll go around our virtual roundtable and just get a sense of what everybody experiences within their own country. As we said earlier, we want to get that global perspective. And so one of the things that is obviously important for us to touch upon is educating our patients. So as healthcare professionals, how do we educate our patients when we are faced with either a new prescription for hormonal therapies or somebody who is pregnant or in the postpartum state? How are we conveying that information about thrombosis risk in those different states? And perhaps, Fionnuala, I'll start with you, and I'm going to use our first names just for more of an informal discussion, if that's okay.
Yeah, thank you, Elena, and thank you, Naomi, for a truly outstanding talk. Congratulations on this enormous and impactful body of work. So yes, to your question, Lena, in Ireland, there are specific recommendations, both already existing and soon to be updated, on the education of women in particular, in many of the areas which Naomi has covered. And as you know, one of the areas closest to my own heart is the area of thrombosis prevention in pregnancy and awareness. So in Ireland, a couple of years ago, the National QPS, or Quality and Patient Safety Directorate, issued fantastic resources in partnership with Thrombosis Ireland, our patient safety, our patient organisation, including thrombosis alert cards. And these cards are intended to be provided to all people upon hospital discharge, ideally in the community as well, but also including women who have recently had a baby, because of course one of the risk factors for developing a clot or a clot in the veins, a blood clot of VTE in the postpartum in general is having had a recent pregnancy and delivery. But there are gaps, and there is a long way to go to ensure that this education reaches every person in every part of the country. And working with the Chief Clinical Office and the National Clinical Design Office, we will be ramping this up in years to come. Watch this space.
That's great. Thank you, Fionnuala. And Helen, can you tell us how things are in Nigeria with educating patients about the different VTE risks and through the different stages of their journeys? Oh, Helen, you're just on mute. If you could unmute yourself.
Thank you, Lana. Thrombosis, particularly in women, is gaining recognition as a public health issue in Nigeria due to the rising risk factors like obesity and sedentary lifestyle. Just to give you a little bit of a background, according to a study or studies published a couple of years ago, The study assessed the knowledge of women receiving oral hormonal contraceptives. Up to 65 to 71% of these women said they were not informed. They had no formal education on thrombosis risk. Then on the other hand, the healthcare professionals, we had up to 65% of them saying that they had no guideline to follow. That being said, there's currently no structured national health education program specific for thrombosis risk in women. At the institutional level, we do different things. All these are driven through coagulation specialists or other healthcare professionals. They're also driven by governmental and non-governmental organizations, as well as international health bodies. For instance, while educating women on thrombosis, you can have nurses giving health talks during clinics. You can also have workshops, tailored workshops, and seminars for these women. So that's about how they are educated. Thank you.
Thank you for that, Helen. Sounds like we have some opportunities there to increase awareness in Nigeria. So this is exciting. Hopefully we can help with that. Danny, I'll turn to you and you can tell us about your experience in Australia.
Unfortunately, probably pretty much mirrors what's happening in Nigeria, unfortunately, in that there is no coordinated national, I guess, public awareness program. I certainly always look in awe with sort of Thrombosis Ireland, Thrombosis UK, and sort of our Canadian colleagues in that there's obviously a strong thrombosis, I think, advocacy through different associations. Very recently, my lovely colleague, Professor Ross Baker in Perth, has set up, I guess, a Thrombosis Australia sort of website. And so that's sort of the seedling that's been planted, I suspect post-COVID. And, but really prior to that, there's really no public-facing, I guess, really resource that our patients can actually access. So really most of the education and awareness our patients get really through their primary care providers or sadly, if they've actually encountered a thrombotic event and sort of secondary, I guess, prevention after seeing, a specialist. So really, there's certainly a much, much, much more we could do, I think, in Australia in really shining, I think, the light on I guess, the risks of thrombosis in women's health. And look, I'm certainly very keen to hear and learn from my colleagues around the table here on what sort of initiatives that we could start to sort of set that in motion, I think.
Thank you, Danny. That's great. I'm going to ask specifically Naomi and Fanula, given that your countries have access to certain hormonal contraceptions over the counter without a prescription per se, what type of counseling is done? And is that counseling done by a physician, by a nurse practitioner, a physician assistant, a pharmacist? If you could give us a sense of how that is explained, and in particular, if there's thrombosis risk that's explained to purchasers of these hormones. And perhaps that would be a great opportunity for us to incorporate that into our next steps as different countries. Naomi, I'll start with you.
Sure. So it is challenging to do the counseling, in a clinical setting, especially if you have a 10-minute clinic visit. And to counsel about the range of options and the risks of thrombosis with different options. The good thing about the progestin-only pill is that there really does not seem to be an increased risk for thrombosis, even with medical conditions. There are very few that I can think of. I think maybe current breast cancer, where there would be concern for a person using it. But it's a great candidate to be over the counter because it tends to be less risky. There is an effort in the US to have pharmacists be more equipped to do some of this counseling, and education for pharmacists so that they can help educate the patients. But I think there's a lot of work to do, and it is really challenging to fit these sort of complex concepts into a quick visit.
Absolutely, that can be a very challenging thing. So I think it is certainly a multidisciplinary effort when we're talking about counseling our patients and educating them. Finola, please tell us how you tackled this in Ireland.
Yeah, like Naomi, there's still a lot to do, but the intention is there. So as you probably know, Lena, the access to free contraception was expanded recently, which is great. So a funding stream was put in place to provide patients up to age 35 now with access to free contraception, which is terrific. And there is an ongoing large body of work to generate some guidelines and KPIs on what kind of information should be provided to people looking to access this contraception. And yes, I'm happy to say that thrombosis risk is included. So in terms of who provides this information, this hasn't been stipulated yet to my knowledge, and certainly not audited. But I think, given the given practicalities, the majority of counselling will probably take place in primary care offices, which highlights the crucial importance of bringing our primary care colleagues to the table and involving them in all stages in any work plan around thrombosis education. And we're thrilled to hear that this is happening in other countries as well. Thanks, Lena.
Thank you, Finola. I'm going to change gears a little bit and ask each of us to comment on whether or not your hospital, your region has VTE protocols in place for risk assessment for women at various stages. But also in particular, I'd like us to talk about pregnancy and the postpartum state. We've spent some time on use of hormonal therapy. So I'd like to talk about pregnancy and postpartum. And Helen, I'll begin with you. If you could tell us about risk assessment models in Nigeria.
Okay, in Nigeria, we have risk assessment models in place. First of all, let me talk about the guideline. We have a guideline, a protocol in place, the guideline for management of venous thromboembolism in Nigeria, which was developed by the Nigerian Society for Hematology and Blood Transfusion in 2018. This guideline has been widely circulated and across the country. However, knowing that Nigeria is a very large country, we have different people, different institutions doing different things in their institutional levels. So there is a well-adopted VTE protocol aside that for the national guideline that has been in place in certain hospitals like the University of Nigeria Teaching Hospital Enugu, the National Hospital Abuja, and few other centers. However, it's important to note that currently there is no national or institutional VTE protocol that is tailored to family planning clinic or oral contraceptive use. But recently also, the OB, Obstetrics and Gynecology Society of Nigeria, has developed a guideline for management of patients, obstetric patients with venous thromboembolism. Thank you.
That's excellent. Thank you. Danny, I'll ask you the same question. Are there any risk assessment models that are used in Australia to help with this?
Yeah, so thankfully, I think in the patients when pregnant, we have a much more robust, I think, streamlined risk assessment, protocol, really for primary care providers as well as in the hospital setting. So starting with sort of the primary care providers, we're quite lucky, certainly specifically in our sort of local health district, there's actually an online risk assessment tool that actually patients can actually hop on and take this survey, which essentially, assesses their risk. And in fact, we recommend whether they should be referred essentially to to, I guess, a high-risk antenatal clinic. Similarly, GPs can also hop on and do the same, risk assessment, and we steer them towards, I guess, towards a high-risk clinic. I think one of the things I'm very proud of, given that we're quite a culturally diverse part of Sydney and New South Wales, that actually front-facing website is actually in multiple languages. So the two sort of main, cultural groups is sort of Middle Eastern and also our Vietnamese population is actually translating those languages as well. So that was a huge, I think, project that was taken on by our local health district. I guess once a patient gets referred to the antenatal clinic, there's then very well established, I think, pathways pretty much throughout most states in Australia, really quite integrated into our sort of antenatal risk assessments.
That's fantastic, Danny. Really curious to see what that survey looks like. It'd be wonderful to be able to disseminate that. Fionnuala, I'll ask you how you assess risk.
Of course, and first of all, Danny, that is very exciting, the initiative that is embedded in a patient-facing questionnaire in many, many languages. Congratulations to you all. Yes, so since, for many years, the National Quality and Patient Safety Directorate has endorsed and recommended a single-page, hospital-based risk assessment tool for guiding thromboprophylaxis in hospitalized patients, Lena. And we know, just like so many areas in the world, that there is a gap between what is ideal risk assessment rates and what actually happens on the ground. And this is a key priority for the National VT programme and for the National QPS Directorate. It is audited and is, improving in many, many areas thanks to various strategies that have been implemented, but there is a long way to go. In pregnant women, I'm delighted to draw attention to one particular region, and particularly the Rotunda Hospital, where, led by my colleagues, Professor Brian Cleary and Professor Jennifer Donnelly, with Dr. Fergal O'Shaughnessy, an electronic risk assessment model has been implemented. And in that hospital, rates of of risk assessment of over 97 and sometimes over 99% on a consistent basis in the control phase of this QR project have been recorded. So look, it can be done when there's buy-in and when stakeholders are invested in the story and whose hearts are in the project. So respect to you, Danny, and the implementation of your own project. And I think we can all learn from each other to do better.
That's really exciting work, Fionnuala. Congratulations to you and your team. And Naomi, tell us about how that approach is done in the United States for risk assessment.
Yeah, I really, I am impressed with your efforts. That sounds amazing. And unfortunately, in the US, our healthcare system is fairly fractured, and individual hospitals and hospital systems sort of tend to do their own things. We have some national guidelines from our professional societies, the Society for Maternal Fetal Medicine, the American Society of Hematologists, but then it's sort of left to individual systems to implement their protocols. And I think better guidance would be really helpful. More clear guidance for how to implement this would be really helpful.
Thank you. It sounds like we have many opportunities to learn from each other. And I think that's a really exciting thing about a roundtable discussion like this. I'm going to ask, for those that do have risk assessment models or deem that a patient is high risk during pregnancy or the postpartum state, and you want to provide thromboprophylaxis, how easy is it for you to do that within your respective countries, considering things such as access to medication, cost of medication, and how do you navigate those potential challenges? Danny, if it's okay, I'll start with you.
Yeah, thank you, Elena. So we're quite fortunate in our access to lumaculate heparins. They're widely available and can be prescribed by primary care physicians as well as, I guess, specialists. So really, for us, thankfully, it's really no barriers to access for chemical thromboprophylaxis anyway. Yeah.
And Helen, can you tell us about the experience in Nigeria for those that need thromboprophylaxis? You're just on mute, Helen, if you don't mind unmuting.
Okay, for women that are found eligible for thromboprophylaxis through risk assessment tools, we use heparin for heparin is the drug of choice for pregnant women. And for the non-pregnant women, you can use any of the other drugs like warfarin and Dowax. Accessibility, these drugs are fairly accessible. There's a great disparity in the social status of individuals in Nigeria. For the high and middle society, individuals, they can get that without any stress. But the low income individuals, they have a bit of stress because these drugs are not subsidized in our hospitals. They are not, there is no well-structured health insurance on the national level. So it may be a bit difficult for these individuals to get them, but the drugs are available. It's whether they're accessible due to cost that is the issue.
Thank you, Helen. And Naomi, if you could tell us the experience in the US.
Yes, I think similarly, we have a lot of challenges with insurance coverage and access to the medication. The medications are available, as Helen said, but insurance coverage may be challenging. For pregnant people, generally there is sort of a global fee that the insurance covers for the entire pregnancy and postpartum period. And so usually that is less challenging because if a person needs thromboprophylaxis, then it would be covered as part of the global obstetric fee. But we again certainly have a lot of work to do on ensuring that everybody has access to the medications, including those. We have a lot of people in the US who are not insured at all. And so, ensuring access for them is a challenge, but really important.
Thank you. That's really interesting to hear about our experiences worldwide, some with easy access, if you will, and others facing challenges. And this is going to bring me into my final question for our expert panelists. And it's related to what are the major barriers and challenges in addressing thrombosis risk and management in women within your respective countries? And we've heard a little bit about what we just talked about, but how else are there challenges and barriers and perhaps a solution if you have one that we can? Finola, I'm going to put you on the spot.
Okay. We'll be honest, lots and lots of barriers, in particular in reaching every person, every woman who is menstruating, every pregnant person out there, because it's not good enough that we only target those who come to our attention, but rather that we spread these messages within the community. And I can see that my colleagues around the table have similar issues. I'm delighted to say that on World Patient Safety Day, which was recently celebrated, the Thrombosis Ireland organisation, working with the National VT Programme and the National Quality and Patient Safety Directorate, and a huge shout out to Shima Lungari, produced beautiful resources that are snackable resources that can be disseminated and were disseminated on platforms such as TikTok and Instagram and Twitter. They were produced and disseminated in a format that is very understandable. And we do need to get these translated and make sure, like Danny has highlighted, and make sure that they become available to all. But that is one idea, particularly for a younger cohort of people.
That's exciting. Thank you, Fanula. Helen, I'll ask you the same question, challenges and barriers.
Yeah, in Nigeria, we have a number of challenges. First of all, the challenge of finance, poor infrastructure, limited resources, but I'll leave that because we all understand. I want to talk about superstitious belief, cultural and social belief. These have been an impediment, great impediment in access to health care or even receiving treatment for some patients. You can imagine someone that has traveled to the village, who has embarked on a long distance travel, comes back with swollen leg, unilateral swollen leg. He believes that it's the enemy in the village that has struck. He wouldn't want to go to the hospital. She wouldn't want to receive care. She would rather go to maybe a herbalist or a church or religious gathering to pray about it. So these have affected the health-seeking behavior of our people. Another important challenge is that of cultural barrier, cultural beliefs. You know, in Nigeria, women are not really allowed to take decisions, important decisions, when it comes to their health. Before they take such decisions, like you have a patient come to the hospital, you tell the patient, oh, your risk is this, I want to place you on thromboprophylaxis. She'll be like, excuse me, let me go and take permission from my husband. Let me take permission from a male family member. So this is what we see. Then other social beliefs about thrombosis, how it affects childbearing, with all those myths. Before these people, they have low awareness of thrombosis, and we keep doing it. We keep enlightening them on the true things about thrombosis, the fact about thrombosis.
Thank you, Helen. That's really important to factor in the cultural components. Thank you for reminding us of that. Naomi, I'll ask you next.
Yeah, so I think we have talked about a lot of the challenges that are also present in the US for people to access the care that they need. I think a major barrier is awareness and education for people in the population. I don't have a general solution to this. At CDC, we do have some resources available. So CDC works with the National Blood Clot Alliance on some educational tools, both for healthcare providers, but also for the general public. So things like recognizing the signs and symptoms and knowing, when to access care. So we hope that some of these, educational materials are accessible and are used, but certainly I'm learning a lot of great ideas from this panel. So I'm really excited to think about how we could implement some of these measures.
Thank you, Naomi. And Danny, I'll have you close out the question. Tell us about barriers and challenges in Australia.
Sure. Look, I think really what's clear to me, really having, being involved in World Thrombosis Day committee and really, self-reflecting, the biggest, I think, challenge we have is really with public awareness campaign. I think we're blessed in a country where with our universal healthcare, diagnosing and treatment, thankfully, it's, it is almost, we will take it for granted. But the preventative measures, though, when I look around, in terms of, I think I mentioned previously, looking at the amazing World Thrombosis Day campaigns out there all around the world, we are far, far behind in terms of trying to raise public awareness. And really, I feel that the three key areas that really, I think, I really want to try to push forth, I guess, in Australia is, well, women, empowering women in terms of, being aware what are some of the symptoms of VT, just the basics. Number two, of course, specifically for in women's health, what are the risk factors? So there's hormone, obviously, exposure as well as pregnancy itself, but also reflecting that the safety also of hormonal therapies, because I've seen so many women who are on anticoagulants for horrendous, heavy menstrual bleeding, who are denied hormone therapies just due to ignorance and literally getting regular iron infusions when they should be on probably some sort of hormonal therapy that's safe. So, I think we've got a lot of work to do in Australia, and, certainly I think with our resources, surely we'll be able to make a difference. And that's sort of really why I'm very passionate about, especially looking around this roundtable here, inspired by you all. And there's a lot of work to do.
Thank you, Danny, and thank you all to our panelists. This has been a really exciting and inspiring discussion. I think we have learned a lot from each other. Dr. Tepper, I would really like to thank you for your excellent presentation and sharing that updated information from the United States CDC partnership there. We very much value the partnership that we have with the CDC on an ongoing basis, and we thank you from the World Thrombosis Day campaign. I would like to take this opportunity to remind our audience that World Thrombosis Day falls on October 13th, and there are many ways that people can become involved in World Thrombosis Day, sharing that messaging and making people aware. And you can see our social media opportunities on our website, which is www.worldthrombosisday.org. We would really love to see your activities, so please share them with us on social media and we can help to promote them. Again, thank you to everybody, and I wish you all a great day.